Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This episode is our second episode on hereditary cancer syndromes in gynecologic oncology. Today, we're going to be discussing the management of patients with specific hereditary cancers. Sydney, what are our learning objectives for today?
Our learning objectives are to discuss the management of hereditary breast and ovarian cancer syndrome, which results from BRCA1 or BRCA2 germline mutations, to discuss the management of other germline mutations which predispose to ovarian cancer, which have moderate or low penetrance, to review the gyn implications of Lynch syndrome and management recommendations, to review management of less common hereditary cancer syndromes predisposing to gynecologic cancers, and to discuss recommendations for management in the setting of a positive family history with negative genetic testing.
So let's talk about the actual syndromes that are most common in GYN oncology. We'll structure them by disease site. Sydney, can you talk us through ovarian cancer hereditary syndromes?
Yes. Let's start with BRCA1 and 2. We recognize that a lot of this will be review, so we'll try to hit the highlights of more complicated pieces. Management of BRCA1 and 2 patients depends on their specific mutation and their age at diagnosis. For premenopausal patients desiring future fertility, it's important to refer them to a fertility specialist. If patients are interested in IVF and genetic testing of the embryos, they can test for pathogenic BRCA mutations in the embryos and prevent passage of this gene to offspring. Management of BRCA1 and 2 mutations, when thinking about gynecologic cancers, is all about prevention. BRCA1 patients have a lifetime risk of ovarian cancer of 39 to 46%, and their annual risk of ovarian cancer starts to increase compared to the general population around the age of 35 to 40. For patients with BRCA2, their lifetime risk of ovarian cancer is 13 to 27%, and their risk increases around age 45. Recommendations for risk reduction are based on this. Surgical risk reduction with BSO is recommended for patients with BRCA1 mutations between the age of 35 to 40, and for those with BRCA2 mutations between the ages of 40 to 45. Risk-reducing BSO in BRCA1 and 2 patients has around an 80% lifetime risk reduction for ovarian cancer. There is still a small risk of obtaining a primary peritoneal cancer after risk-reducing BSO, which is less than 1% of a 10-year risk. In patients with BRCA1 and 2, that risk increases significantly if a serous tubal intraepithelial neoplasia, sometimes called a serous tubal intraepithelial carcinoma, is identified at the time of risk-reducing BSO. At the time of surgical risk reduction, there's about a 1% chance that an occult malignancy will be identified, and between a 4 to 12% risk of finding some occult neoplasia, like a STIN. In different studies, the 10-year risk of a primary peritoneal carcinoma in the setting of a STIN at the time of BSO has been reported at 5 to 27%. Maya, I mentioned risk-reducing BSO for BRCA1 and 2 carriers. Can you review the special considerations needed when performing a BSO for ovarian cancer risk reduction versus a BSO for benign indications?
Yes. Again, a lot of us learn this in residency. Typically, when working these patients up for surgery, a pelvic ultrasound and a CA-125 level are obtained to make sure there isn't a malignancy or concerning findings that would change our strategy and to help with surgical planning. There are some specific intraoperative considerations when performing a risk-reducing BSO. The principle behind these techniques is the goal of eliminating or minimizing as much as possible the chance of leaving behind residual ovarian tissue or missing an occult cancer diagnosis. First, it's important to get pelvic washings upon entry to the abdomen. Then a complete abdominal survey should be done, looking for any unexpected lesions. Peritoneal biopsies are recommended. When performing the BSO, the gonadal vessels should be transected around 2 centimeters proximal to the end of any visible ovarian tissue. The specimen should be placed in a laparoscopic specimen bag for removal. The last piece of the technique is with pathology. When sectioning the specimen, pathologists should use the C-FIM technique, which stands for sectioning and extensively examining the fimbriated end of the tubes. Essentially, this is microsectioning to get a more detailed analysis. Earlier, we mentioned the possibility of detecting an occult cancer or a serous tubal intraepithelial neoplasia at the time of risk-reducing BSO. If an invasive carcinoma is detected, then the patient should undergo full staging and treatment as with any ovarian cancer, depending on the stage. If an intraepithelial lesion is diagnosed, patients should always be referred to gyn-onc to discuss the implications of this. As we mentioned before, there's data that in patients with a BRCA1 or 2 mutation who have a STIN, there's an increased risk of developing peritoneal carcinomatosis down the line, even if no invasive cancer is diagnosed at the time of the original surgery. There isn't a firm recommendation from any governing body about how to manage these STIN lesions. Options include observation with or without CA125 or ultrasound surveillance, full surgical staging, and consideration of chemotherapy administration to reduce the risk of peritoneal carcinomatosis. Practices likely vary by institution. After BSO, premenopausal patients should all be recommended to take hormonal replacement therapy unless they have specific contraindications. This is safe and life-saving for our patients. HRT reduces the risk of all-cause mortality in patients who have had a premenopausal BSO. It improves bone, cardiac, and brain function. Failing to give HRT when there are no contraindications can create harm for our patients. We've talked about BSO for risk reduction, but I've also seen people performing self-injectomies without oophorectomies for some patients. What's the data on that practice?
So there's not yet data on whether this approach is safe from an oncologic standpoint. It's an area of active research. We have data from the non-BRCA hereditary cancer world that salpingectomy reduces the risk of ovarian cancer by about 50%, but we don't have that same data in BRCA 1 and 2 patients specifically. At this time, there are 2 ongoing trials evaluating safety and efficacy of salpingectomy with delayed oophorectomy. The first is called SOROC. This is open to premenopausal patients with BRCA1 mutations and is a non-inferiority trial of bilateral salpingectomy with delayed oophorectomy versus upfront BSO. Study completion is expected in 2037. The second study is called TUBA-WISP-2. This is building off the results of the TUBA trial conducted in the Netherlands, which compared risk-reducing salpingectomy followed by delayed oophorectomy to risk-reducing BSO, with the primary outcome being menopause-related quality of life. Hormone replacement therapy was recommended for patients without contraindications after BSO. This study suggested that even with hormone replacement therapy for BSO, patients with salpingectomy followed by BSO have better menopause-related quality of life. In the WISP trial, primary outcomes are changes in female sexual function, and the WISP trial does include rates of ovary, fallopian tube, peritoneal malignancies between arms as one of their secondary objectives. The TUBA-WISP-2 trial is ongoing and recruiting and is employing a non-inferiority trial design to evaluate risk of cancer between patients who undergo BSO versus salpingectomy followed by delayed oophorectomy. Results from that trial are expected in 2037, so we've got a ways to go. The takeaway here is, while it's exciting that salpingectomy with delayed oophorectomy may be a great option for our patients, we don't yet know if it's equivalent to BSO in terms of cancer risks. For now, this should be done only in the context of a trial. Encourage your patients to enroll if interested. Maya, how does hysterectomy play into these decisions?
Great question. There's some data that there is a slightly higher risk of serous uterine cancer in patients with BRCA1 mutations and perhaps with BRCA2, but the data is conflicting. In a Dutch study by De Jong in 2021, they observed a 2 to 3-fold increased risk of endometrial cancer, mainly serous or P53 mutated cancers. In a systematic review and meta-analysis by Matanes et al. In 2021, There was no difference in the risk of endometrial, including serous cancers with BRCA1 and 2 carriers. Some of the increased observed risk may be due to a history of tamoxifen use in these patients. Performing a hysterectomy does simplify the administration of HRT after risk-reducing surgery because progesterone would no longer be required. The cons are that a hysterectomy requires significantly longer recovery and has higher surgical risk. So given the above, this can be considered and discussed with your patients, but it's not specifically recommended. Sydney, what about non-surgical risk reduction?
Non-surgical risk reduction is also an option. The use of combined oral contraceptives has been shown to have significant reduction in the risk of ovarian cancer in BRCA1 and 2 carriers, and the longer patients use OCPs, the larger relative risk reduction. The levonorgestrel IUD has been shown to reduce the risk of ovarian cancer in the average risk population, but has not yet been studied in BRCA1 or 2 mutation carriers. Finally, for patients not desiring or not ready for surgical intervention, you can consider following them with pelvic ultrasound and a CA-125 once they're in the age range where surgery is recommended. It's important for us and our patients to understand that this does not decrease mortality from ovarian cancer, and in the studies that have been done investigating screening for ovarian cancer, there has been an excess of surgeries, imaging, labs without a reduction in ovarian cancer mortality. However, it may allow us to identify cancers earlier if they do pop up. This is a controversial strategy. Finally, remember that for your patients with a BRCA1/2 mutation, they need to be referred to a breast surgeon to start discussing imaging and surgical risk reduction, given the about 80% lifetime risk of breast cancer in these patients. Patients with BRCA1 and 2 mutations are at risk for pancreatic and gastric cancer, as well as an increased risk of melanoma in patients with BRCA2 mutations. While these won't affect our patients, there's an increased risk of prostate cancer and male breast cancer in BRCA2 mutated males.
Thanks, Sydney. For our next discussion, I want to keep us in the realm of the ovaries and discuss some other syndromes which increase the risk of ovarian cancer. RAD51C, RAD51D, BRIP1, and PALB2 are all proteins involved in DNA repair, which, when mutated, increase susceptibility to ovarian cancer. As we mentioned previously, these mutations all have low to moderate penetrance, which results in different risks for ovarian cancer. Recommendations in the national guidelines for moderate penetrance genes for ovarian cancer are based largely on data from BRCA1 and BRCA2. In general, for risk-reducing BSO, some people use a cutoff of about a 10% lifetime risk of cancer to offer risk-reducing surgery. But at the end of the day, these conversations are highly individualized and depend on the patient's priorities, personal experiences, family history, and factors such as age. Patients with RAD51C and RAD51D mutations have up to a 15 and 20% lifetime risk of ovarian cancer, respectively. Because of this, the NCCN recommends risk-reducing BSO starting at age 45 to 50. BRIP1 germline mutation carries a lifetime ovarian cancer risk of up to 15%, and so like RAD51C and D, is recommended for surgical risk reduction with BSO at age 45 to 50. PALB2 is a protein which helps localize BRCA2 in DNA repair. Mutations in PALB2 carry up to a 5% lifetime risk of ovarian cancer, which is lower than that 10% threshold we mentioned. Because of this, the NCCN carries a consideration for risk-reducing BSO starting at age 45 to 50 in these patients. As always, a risk-benefit discussion with your patient will be the best way to make a decision. Some other mutations like germline, ATM, and STK11 increase the risk of ovarian cancer slightly, but not enough where risk-reducing BSO is routinely recommended. Incorporation of family history results can help guide counseling. The last population we want to discuss is patients with a positive family history for ovarian cancer who don't have a known pathogenic mutation and have negative genetic testing. A first-degree relative with ovarian cancer confers about a twofold increased risk of developing ovarian cancer over the lifetime. So our best estimate for lifetime ovarian cancer risk in these patients is about 4 to 5% with one first-degree relative, and maybe around 8 to 10% with two first-degree relatives with ovarian cancer. There aren't specific guidelines for management in the setting of a strong family history of ovarian cancer, but based on the principles we've discussed, it is reasonable to discuss risk-reducing surgery for these patients. Sydney, I think there's one more hereditary cancer syndrome, which can significantly increase the risk of ovarian cancer. Can you tell us about Lynch syndrome?
Of course. Cancer risks associated with Lynch syndrome are very mutation dependent. MLH1 and MSH2 mutations have the highest risk for colorectal, up to 80%, and ovarian, up to 24% cancer. Endometrial cancer risk is high in MLH1 and MSH2, up to 55%, and in MSH6, up to 70%. MSH6 also has an increased risk of ovarian cancer, up to 16%. PMS2 is, quote, the weakest Lynch mutation. Colorectal cancer risk is up to 20%, endometrial about 15%, and there's no increased risk of ovarian cancer. Let's start by talking about management of endometrial cancer risk in Lynch syndrome. The most important piece is patient education about abnormal uterine bleeding, pelvic pain, or bloating, which should all trigger an evaluation. Endometrial cancers from Lynch syndrome more commonly arise in the lower uterine segment, and most are diagnosed at stage 1. Because of this, outcomes are relatively good. Risk-reducing hysterectomy due to these factors has not been shown to decrease mortality from endometrial cancer in patients with Lynch syndrome, but can be considered starting at age 40. In patients with MLH1 or MSH2 or MSH6 mutations, you can consider risk-reducing BSO. For patients with PMS2 mutations, a risk-reducing hysterectomy can be considered for patients starting at age 40. In these patients, oophorectomy before the age of natural menopause, about 51 years, is not recommended as the risks outweigh the benefits. Maya, aside from surgery and symptom detection, are there other management strategies for Lynch syndrome?
Yes. Starting at age 30 to 35, it's reasonable to consider an annual endometrial biopsy in patients with Lynch syndrome. This has not been definitively proven to improve outcomes for patients with Lynch, but it can help with early detection and is an option before surgical risk reduction. As discussed in our first hereditary cancers episode, it's crucial to make sure these patients are plugged in with a GI prevention clinic and genetic counselor. Patients with Lynch are at risk for gastric and colon cancer, as well as urothelial cancer. There are specific screening recommendations for each of these. Okay, let's finish off talking about a few more rare hereditary cancer syndromes that have gynecologic cancer implications. Germline P10 mutations cause Cowden syndrome, which is associated with endometrial, colon, and breast cancer, along with other benign neoplasms. These patients are recommended to have an annual comprehensive physical exam starting at age 18 or 5 years before the youngest age of diagnosis of cancer in a family member. For endometrial cancer, their lifetime risk is about 20%. There aren't specific risk reduction recommendations for endometrial cancer, but like with Lynch syndrome, education about symptoms of cancer is paramount. Endometrial biopsy screening every 1 to 2 years can also be considered. Patients can also be counseled about considering a risk-reducing hysterectomy, leaving the ovaries in situ after completion of childbearing.
Awesome. That's all that we have for you today, but we hope that you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Hereditary breast and ovarian cancer syndrome is a result of a germline mutation in BRCA1 or BRCA2. The lifetime risk of breast cancer with both of these mutations is about 80%, and the lifetime risk of ovarian cancer is up to 46% and 27% for BRCA1 and BRCA2, respectively. Surgical risk reduction is recommended, starting at age 35 for patients with BRCA1 and 40 years of age for those with BRCA2. These patients are also at risk for pancreatic cancer, gastric cancer, and melanoma. Risk-reducing self-injectomy with delayed oophorectomy is under investigation as a non-inferior approach, but results are not expected for another decade.
RAD51C, RAD51D, and BRIP1 are moderate penetrance mutations which increase the risk of ovarian cancer to a greater than 10% lifetime risk. As such, risk-reducing BSO is recommended for these patients. For mutations with a lower risk of ovarian cancer, such as PALB2, risk-reducing BSO can be considered.
Lynch syndrome is associated with an up to 70% lifetime risk of developing endometrial cancer, depending on the specific mutation. Risk-reducing hysterectomy can be considered for patients with Lynch starting after age 40 or completion of childbearing. For patients with MLH1, MSH2, and MSH6 mutations, the risk of ovarian cancer is more than 10%, and a risk-reducing BSO can also be considered. PMS2 mutations increase the risk of endometrial cancer, but not ovarian cancer. Patients with Lynch are also at risk for colorectal cancer, gastric cancer, and urothelial cancers. Prior to surgical risk reduction, education about abnormal uterine bleeding is crucial, and endometrial biopsy should be employed for evaluation of symptoms. Endometrial biopsy can also be considered as a screening strategy.
Cowden syndrome results due to a germline PTEN mutation and increases the lifetime risk of endometrial cancer up to 20%. There isn't a specific recommendation for management of Cowden syndrome, but strategies similar to those employed for Lynch can be considered.
Patients with a positive family history of ovarian cancer but negative germline testing have an elevated risk of cancer, which increases with the number of affected family members. Family history can be used to guide discussions of risk management, which can include risk-reducing BSO. This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Taylor Oriana, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.